Hi, my name is Yi Tae, and welcome to my session for soft tissue cellulitis and angioedema, as well as deep vein thrombosis. The goals and objectives of this particular talk includes the indications for such studies, the probe that we will be using, how to acquire the images, and review of the normal anatomy, as well as abnormal findings, and the pearls and pitfalls of these studies. We'll be starting with soft tissue cellulitis and angioedema. The indications for the study includes differentiating between what is normal skin versus infection, as well as determine if there's any local skin reaction that occurs. This will help us in assisting for a treatment plan. The probe that we will be using is a linear transducer. It's a high-frequency probe of 5 to 10 megahertz. We generally put them on a superficial setting or for small parts. So for image acquisition, you want to be able to use the linear probe, and you zoom in on your monitor and your machines as needed so they can acquire the image that you want to see. You put the probe onto the skin itself, and if you need a barrier between this open skin and the probe, you can put a tegaderm over the probe. You place a probe on the area of interest if it's red, if it's swollen, if it's a painful area. And I generally recommend lots of gel, but don't press too hard on the gel because it can also act as a step pad so that it can elevate that area so that you can take a look at a better image on your ultrasound machine. Another way to achieve this is to use the water bath. Using the water bath, the probe actually does not touch the patient, but it uses the water to conduct that sound wave so that you can avoid touching the patient in case if they're in pain, and also acquire a better image because you're not pressing down on the patient's skin. A review of the normal anatomy includes you have the dermis on the top, and underneath it is the subcutaneous area. Sometimes you may see fatty tissues there. It's divided from the muscle by the fascia, and the rest that you would see here is the muscle layer. If you're unsure of what's normal and abnormal, you compare it to a surrounding skin area as well as any contralateral side for comparison. So cobblestoning is a term that we use for patients who may have images that looks like that they may be suspicious of cellulitis. When they have cellulitis, they may have fat lobules that you'll see here, just round lobules that look very much like a cobblestone, hence the term of cobblestoning. This generally occurs in the subcutaneous area, and it's within the thickened skin. Here we have examples of what cobblestoning looks like. On the left side that you can see these lobules. On the right side here, the arrows are indicating what the cobblestones actually look like. But this can indicate that there may be a cellulitis process that's occurring. For cellulitis, you can have thickened skin, as you can see here, may not quite develop into the cobblestone just yet, but sometimes this may come as a later process. In terms of angioedema, if you have a patient who may have been stung by an insect or some sort of a sting, instead of having cobblestoning, they may have what we call the linear bands of edema that you see here. The skin will still be thickened, but the subcutaneous tissues may be divided by just these linear bands that you see here on the left side on the video, as well as on the right side here. So with cellulitis, you see cobblestoning. With angioedema, you see bands of edema. So they may look similar, but just remember the cellulitis really does look like cobblestoning, but with a thickened skin. And with angioedema, you just see linear lines. So some pearls and pitfalls that we do on this study is that if you overcompress, if you press too hard, you will obscure the landmark and displace the tissue. And if you're unsure, you compare to the contralateral side or the surrounding unaffected skin. For skin infections or local allergic reactions, sometimes you can consider using a water bath, and especially that works well for both the hands and the feet. And if you have local allergic reactions in angioedema, the ultrasound really works best to really bring out the angioedema on the hands, feet, and the surrounding eyes. If you have periorbital edema, The other areas, I don't find them to be quite as reliable in trying to take a look at the bands of edema. So let's go over a case. There's a 70-year-old boy who was trying to step on a wasp that was flying around, but instead the wasp stung him instead. That was a day before, and so he's coming to you today. His foot is now swollen, it's itchy and it's painful, but he does not have any fever and there's no medications that was given to him. And this is what his foot looks like on the right side. He has no fever and no tachycardia on exam, and his right foot is swollen. It's not warm, it's just painful to touch and is quite swollen. There is a punctum in the center of the swelling, but there's no discharge coming out, and he is able to bear weight. So what are your differential diagnoses? Is this a skin infection or is this a local allergic reaction? You go ahead and do your ultrasound and you see these linear bands that you see in the subcutaneous tissue with thickened skin. So this may be an indication to you that rather you do not see the cobblestone that may indicate cellulitis, but you see these linear bands that may indicate that this may be an angioedema. So the patient was treated with diphenhydramine for a local allergic reaction and ibuprofen for pain, and he was discharged home without any further antibiotics or subsequent return visits. Let's go ahead and move on to deep vein thrombosis. The indications for doing a DVT study includes if there's a leg or groin pain in the area, and if the patient with suspected pulmonary emboli or embolism is being evaluated for extremity involvement. The probe that we use is a linear transducer, again, a high frequency probe that's 5 to 10 megahertz, and we generally put it in the vascular setting. To acquire the image, we use a linear probe and we do what we call a 2-point compression, meaning that we do the compression around the femoral and groin area, as well as the popliteal fossa. We use the color Doppler to assist in identifying any of these landmarks. You look for compressibility, and then you recognize a landmark when the vessel's bifurcation may occur. So you compress every 1 centimeter from the femoral area to the popliteal, up to 5 centimeters. So here you may have the leg a little bit flexed, and you go to the popliteal fossa region, and you go ahead and identify your landmarks, and then you scan at 1 centimeter above and 1 centimeter below. And the same thing may occur also for the femoral area that you see here on the right side. So sometimes it may be helpful, but not reliable. So some of these things that we want to review, including using only the color Doppler to look for filling defects and to detect clots. This is not a reliable technique. It's called augmentation. So using phasic variation, such as changes in Doppler signal by breathing in and out, is also not reliable, although sometimes it can be present. And relying only on clot echogenicity also may not be a good idea if it's not assisted with compressibility. So what you really want to do is look for compressibility in your veins, and doing a 2-point compression rather than the entire leg has shown there has been no difference between the two. So let's take a look at the normal anatomy. The landmarks are the popliteal fossa and the groin canal. So your compression of the vein when you compare it to the artery for vessel patency. So when you press down, if you have a vein in the artery, your artery generally would be patent, but your vein should compress with pressure. Use the color Doppler to assist you. And biphasic and triphasic vessel interrogation, you may be able to perform later on. So here's a review of the anatomy. Generally start with the common femoral vein that can bifurcate into the deep femoral vein, as well as the great saphenous vein. And the common femoral vein generally continues to be at the femoral vein going down and goes into the popliteal vein when it goes into the popliteal region. And it also bifurcates from there. So here on the left side that you see the common femoral vein being compressed, whereas the arteries on above and below are not compressed. They remain patent under compression. Here's an example of the popliteal vein being compressed. You see here that the popliteal artery remains patent, whereas the left side for the popliteal vein is compressed with pressure. On the right side, you see a color Doppler being performed. We're looking for the patency for both the vein as well as the artery. So here are some abnormal findings that you may see. So here you see the popliteal vein being compressed. However, your saphenous vein, when under compression, it looks like that there's something in there. You see some hyperechoic structure within the vessel, as well as the inability to compress fully. The popliteal artery remains uncompressible. So let's take a look at a case. There's a 15-year-old female in a knee immobilizer after a motor vehicle accident for 2 weeks who develops a left leg and groin pain. She also has been on oral contraceptives. You do your physical exam. The vital signs remained no fever and no tachycardia. The exam shows there's left groin tenderness on palpation, no swelling and no tenderness to the back of the knee or the calf. The lung remains clear and there's no shortness of breath or no tachycardia. So you do your study and you see here on the left side that when you're trying to compress here, there is no compressibility on the vein that you're looking at, whereas for the artery that it remains patent, and the vein also remains patent, and there's some echogenic structure that's inside the vein. You do your color Doppler and you see that there is a filling defect on the vein that is just really, the flow is going around the particular echogenic region and this remains non-compressible. This identifies a non-compressible femoral vein, indicating that there is a femoral DVT. This is also associated with the filling defect that you see here. The next step would be vascular surgery consult or initiate treatment as needed. So here's some pros and pitfalls. It's really all about compressibility. Sometimes you may have a DVT above your upper extremities and your bicep tendon may be difficult to compress, as well as your popliteal fossa. That area may also be hard to compress. If you have an obese or uncooperative patient, sometimes that may also be a challenge. So lymph nodes and cysts, as well as Baker's cyst, may look like a popliteal, or rather popliteal area may look like a DVT, but not necessarily. So that's why it would be important, in addition to the compressibility, that you also want to just take a look if there's any color flow, if there's any filling defect, that may help you to determine if this is a DVT or not. So clot echogenicity, the Doppler, as well as phasic variability are very helpful, but not always reliable. So I would not press too hard on the areas of the interest, because you may obscure the landmark and you may actually end up pressing both the artery as well as the vein too hard. For color Doppler, the color does not indicate if it's a vein or an artery, but whether blood is flowing away, which is blue, or towards the probe, which is red. So some of the take-home messages that I want you to get from this particular session is you look for any cobblestoning for patients with any soft tissue cellulitis. For patients with angioedema, you look for bands and lines of edema between tissue planes, especially on the hands, feet, and sometimes on the around the eyelids. Consider a water bath technique for soft tissue imaging so that it can you can maximize your focal point for your ultrasound machine. And if you press too hard, you're going to press away everything, and it may obscure the landmark. And this also includes the DVT studies as well as any soft tissue studies. We recommend a 2-point compression for any DVT studies, and you look for vein compressibility if you suspect a clot. Thank you so much, and I hope that you enjoyed this session.